And so I'm going to talk to you today about, this is a very clinical talk, dermatologic conditions in patients with cancer. We're going to review some challenging cases that I've seen in the outpatient and inpatient Oncodermatology Clinic. These are my disclosures. None of these are relevant for today's talk. And so this is the Yale Cancer Center where I see patients. The Oncodermatology Clinic is located right here, overlooking the beautiful Healing Garden. This is right in downtown heart of New Haven, and there's both outpatient and inpatient units, an ICU, an infusion center, and so really and a phase 1 unit with new experimental drugs. And so we really see patients treated with all different types of cancer therapy. And so the main objectives of the talk is I want to provide an overview of the different oncodermatologic conditions that we treat in patients with cancer, and I really wanted to emphasize clinical pearls and lessons learned from these cases. And so oncodermatology, as you know, is really an emerging and very popular specialty in dermatology that's dedicated to treating skin, hair, nail, and mucosal conditions in patients with cancer. And the way I kind of look at it is that there's problems that arise directly from cancer and cancer therapy. These include toxicities from systemic chemotherapies, cytotoxic ones, newer immune checkpoint and targeted ones, as well as endocrine therapy, radiation toxicities, but also direct extension of cancer onto the skin and cutaneous metastases. But as you'll see, there's also many different kinds of problems that can arise and complications in patients with cancer, including skin manifestations of malignancy, paraneoplastic dermatoses, infectious complications in the setting of immunosuppression, and even late complication years later, including cutaneous carcinogenesis and fibrosis, not to mention graft versus host disease. So for the interest of time, I'm going to focus on these 4 conditions, and I'm going to highlight different cases that review them. And so we'll start off with a case of toxicity from cytotoxic chemotherapy. So this is a case of red hands and feet, then erythroderma. So the patient was a 34-year-old gentleman with AML, and he was admitted for neutropenic fever. He was previously treated with hydroxyurea and an experimental heat shock protein inhibitor, but unfortunately he had disease progression. So now we were consulted for new onset pain, redness, and swelling that were localized to the hands and feet. Of note, he was recently started on cytotoxic chemotherapies with the anti-metabolite combination clofarabine and cytarabine a few weeks prior. His review of symptoms was positive for fevers of T102 max and chills. He also had oral mucositis, but otherwise he was feeling well, no other URI type of symptoms. So he was treated with broad-spectrum antibiotics, as most patients with neutropenic fever are, with vancomycin and zosyn, and he was on prophylaxis with Acyclovir and Cresemba and dexamethasone solution for his mucositis. So when we first saw him, he was febrile to T102, otherwise well-appearing, and as you can see on his hands and feet, he had localized erythematous patches, as well as edema on the hands and tenderness. He reported that he had kind of neuropathic dysesthesia symptoms. And as you can see on the dorsal hands, he also had erythema overlying his MCP joints. So he was treated empirically for presumed typical hand-foot syndrome with topical steroids, but then we were called back a few days later. And so over the next several days, he developed erythroderma now head to toe with dry desquamative scale. And his hands and feet developed worsening edema, and now as you can see, he had painful blisters develop in the setting of this intense erythema and edema. And so the clinical differential diagnosis at this point was toxic erythema of chemotherapy with an unusual erythrodermic manifestation. You always want to consider a drug eruption that can cause erythroderma in the inpatient unit. If the patient had a stem cell transplant, acute graft versus host disease would be considered, but that wasn't the case here. Anytime someone has erythroderma, you always want to consider a primary dermatosis that can then become erythrodermic. He did not have a history of such, didn't look like pityriasis rubipilaris, and paraneoplastic erythroderma is really a diagnosis of exclusion. And so relevant labs, he was pancytopenic, which was typical for him in the setting of his advanced AML. He was pan-cultured, urine, blood, as well as skin cultures, which were all negative. And so histopathology was going to be helpful here. So a biopsy was taken of the arm, and it showed syringosquamous metaplasia of the eccrine glands with a perieccrine lymphocytic and neutrophilic infiltrate with very sparse acute vacuolar dermatitis. But really, the action was centered around the eccrine glands. And so this was typical for toxic erythema of chemotherapy. And so the patient's erythrodermic rash was treated with conservative treatment with topical steroids, open wet dressings, and for his painful blisters on the hands and feet, dilute Dakin soaps. He actually improved over the next several weeks Unfortunately, his fever persisted despite a negative workup and was thought to be tumor fevers, non-infectious pyrexia. And he was unable to go back on chemotherapy because he had multiple hospitalizations, neutropenic fevers. Unfortunately, he passed away. So I wanted to review first toxic erythema of chemotherapy. We see this quite often with patients who are on cytotoxic agents. It's really an umbrella term that encompasses many previous terms in the literature, ranging from hand-foot syndrome, Palmer-Plantar erythrodysesthesia, and neutrophilic eccrine hidradenitis. Most patients present initially with pain, erythema, and edema, often of the hands and feet, but I'll show you, can also involve extensor and flexural zones. The diagnosis is really rendered on clinical history and histopathological correlation. It usually occurs a few weeks after starting chemo, it's dose-dependent, and the pathogenesis is thought to involve a local toxicity from excretion of the chemo and eccrine glands. That's why it's often very accentuated on the palms and soles where there's lots of eccrine glands. The way we manage these patients is mostly with supportive care and topical steroids. Some studies have shown that NSAIDs might be helpful, including Celebrex. Really only severe cases do we use systemic steroids in treatment interruption. And so I wanted to highlight the different spectrum of clinical findings that we see in these patients. And so hand-foot syndrome is the primary way patients present with, these are multiple patients who presented with erythema, edema, and tenderness of the hands and the feet. Occasionally, you can even see the formation of bullae, which is important to know, it can occur. And then certain drugs, such as taxanes, will often present on the dorsal hands. There's actually a syndrome called patio syndrome, periarticular thenar erythema, and onycholysis. Some people think this mimics dermatomyositis. You might see most recently in the literature cases of toxic erythema of chemo mimicking dermatomyositis. I see that quite often. You should know that the dysesthesia seems to be a very prominent symptom. It's pain and also occasionally neuropathic symptoms as well. Patients can also present with intertriginous and flexural zone involvement. And so some will present, this could be diagnosed as SIDRIF, or symmetrical drug-related intertriginous and flexural exanthem. I've seen patients present with erosive patches and plaques involving the scrotal area as well as the inguinal zones as well. Aracy ears is something you may have heard about from cytarabine. Occasionally we see this, and patients can also present with extensor localization. But now I wanted to highlight some of the more unusual presentations to expand your minds on how TEC can present. And so this patient had erythroderma, which was consistent with TEC. But if you look at the literature, there's other cases as well presenting with this generalized erythema and edema. Some of these patients actually had an associated capillary leak syndrome with multi-organ involvement. Occasionally, we've seen patients present with generalized bullous presentations of toxic erythema of chemotherapy. This patient was on clofarabine and cytarabine, just like our patient. And very rarely, TEC can present as Stevens-Johnson-like presentations as well. And so generalized dusky erythroderma with moist desquamation. Many times it's localized to areas of flexural zone involvement. This case actually ended up being fatal. And so there was a recent case report in the literature which really gives us good clues into the pathogenesis of disease. So this patient had unilateral TEC. It spared the axillary vault that was irradiated and had a lymph node dissection. And so after radiation and lymph node dissection, you can actually get sympathetic nerve denervation and eccrine gland dysfunction. So without functioning eccrine glands, you don't have the chemotherapy excreted and causing the toxicity. So I really like that case because it teaches us about the pathogenesis of it. Histopathologically, there's really a variety of features you can see. Interface vacuolar dermatitis and dyskeratotic keratinocytes are actually very common. The more classical changes of eccrine, squamous, syringeal metaplasia happen, but less commonly. And so multiple chemotherapies are associated with toxic erythema of chemo. We see it most frequently from cytarabine, anthracyclines, 5-FU. And this term, I should say, toxic erythema of chemotherapy, was coined at Yale by one of my mentors, Jean Bologna. And I think it's actually a helpful term that incorporates all these different clinical features and histological spectrum of findings. And so can TEC be prevented? A lot of my patients who come in ask me. And so there's mounting evidence that regional cooling can actually reduce the incidence and the severity and increase the latency of onset of TEC. And so some patients will buy these elastogels, these frozen gloves and socks. Others are more crafty, and they'll just use a hazard bag with ice and duct tape around their hands and feet, and that also works. Interestingly, other studies outside the derm literature have shown that regional cooling can reduce the incidence of neuropathy as well, which can be very debilitating. And so For tech, some of the take-home points from the first case is I want you to remember that atypical presentations can happen, including erythroderma and more severe bullous or Stevens-Johnson-like presentations. Most patients will respond to topical steroids and supportive care, and regional cooling can be considered to reduce its occurrence. So before moving on to immune checkpoint inhibitor therapies, I just wanted to highlight some of the problems that patients see me with who are on cytotoxic chemotherapy. So alopecia or anagen effluvium is the most common dermatologic side effect from these drugs. It's usually a total alopecia. Most cases are reversible, but unfortunately, it should be known a certain percentage will actually have permanent alopecia. And this can be really debilitating and impact patients' quality of life. This can happen to maybe 20 to 30% of patients who are on taxanes. These are often young women with gynecologic cancers. Nail changes are incredibly common. Hemorrhagic onycholysis and paronychial infections occur, especially with taxanes. Occasionally, we see severe presentations with subungual hemorrhage and even loss of the nail plate. Mucositis is very common. Hyperpigmentation can occur from multiple chemos. Everybody likes these examples of flagellate hyperpigmentation from bleomycin, but you can get diffuse hyperpigmentation as well as palmar-plantar hyperpigmentation. Occasionally, chemo can extravasate into the soft tissues, and so we've seen some really terrible extravasation reactions. This is an example of a blistering one that required hospitalization and IV antibiotics. He ended up doing fine. Mucositis, also very common, can really impact nutrition and require pain control when it involves the oral mucosa, which it typically does. And this is one of my favorite toxicities because it's benign and no one knows what it is until you see the dermatologist, and that's inflammation of keratoses. And so drugs like 5-FU, capecitabine can inflame AKs, as dermatologists know, but also other chemos, taxanes, can inflame seborrheic keratoses. And so the next case I want to highlight is a case of a novel immune checkpoint inhibitor reaction. And this is a patient who developed blistering lesions while on checkpoint inhibitor therapy for melanoma. And so the patient is a 64-year-old man with metastatic melanoma. He had a thick primary on the right axilla, who started on pembrolizumab, which is an anti-PD-1 therapy. A few months into treatment, he reported worsening pruritus. It was initially managed by oncology with SARNA and antihistamines, but then a few months later, he actually developed blisters now that were localized to his hands and his feet. He had no personal or family history of bullous disease and was on no other new medications. On review of systems, he also had involvement of his oral mucosa, but the rest of his mucosal surfaces were clear. So on examination, on his hands and his feet, he had localized inflammatory tense vesicles and bullae, a very deshydrosiform presentation. And the hard palate of his upper hard palate had a painful ulceration as well. So based on the presentation, we considered bullous pemphigoid secondary to anti-PD-1 therapy. We also considered other conditions that we've seen, such as lichen planus pemphigoides overlaps to anti-PD-1 therapy, bullous erythema multiforme, bullous lichenoid dermatitis, and EBA. So clearly, histopathology and direct immunofluorescence is going to help us narrow this differential. And so histopathology was obtained and showed a subepidermal cleft with eosinophils, and direct immunofluorescence was positive for IgG and complement, consistent with bullous pemphigoid. Indirect immunofluorescence was also consistent with bullous pemphigoid, and titers for BP180 and BP230 were also positive. I often check IgE levels in these patients, and as I'll discuss, they might be interesting and have some therapeutic implications. And so the patient was diagnosed with bullous pemphigoid secondary to anti-PD-1 therapy. So in general, when I see a patient with a so-called immune-related adverse event, if it's low grade, we'll do everything we can to keep the patients on their checkpoint inhibitors. And so I'll often consider conservative therapy. So for this patient, we did high-potency topical steroids with doxycycline and niacinamide, an approach that might be considered a little bit old school, but there is some data to support. And I found that some of these patients do really well. So he was actually able to be maintained and receive a few additional cycles of his immunotherapy, but unfortunately, after a few additional cycles, he really developed more widespread pruritic vesicles. And so at that point, given that his blisters really were becoming more intense and painful and now impacting his quality of life, the decision was made to treat him with prednisone and hold immunotherapy. Unfortunately, upon tapering doses of prednisone, his bullous pemphigoid came back. So at this point, we really needed a maintenance steroid-sparing option here. And so I think it's always good to use a targeted approach for an immune-related adverse event rather than keep patients on long-term steroids. And so with regards to immunobullous disorders, there's really two main drug classes that are used: the monoclonal antibodies to IgE, omalizumab, as well as rituximab. And so we reviewed the safety profile of each of these. He had an elevated IgE level, which in my experience tends to respond better to omalizumab. And so the patient elected for omalizumab. And he actually did very well. We were able to completely taper off his prednisone. He remained on monthly omalizumab and topicals. And at this point, his melanoma had a complete tumor response. And so he remained off immunotherapy, knowing that if he ever needed it again, he certainly would be able to restart it. And so I wanted to briefly highlight these bullous disorders from immune checkpoint inhibitors, because I think they're a really important one to know about, because they often present more severely and can require us to think about systemic drugs. So we did a study at Yale and found that they happen in about 1% of patients on PD-1 or PD-ligand-1 drugs. They don't seem to be associated with the CTLA-4 drugs, although some patients are on dual combinations. What's really interesting about them is, unlike a lot of the other rashes we see, they tend to occur months later on. The average is about 4 to 6 months. I've seen cases develop 1 to 2 years after immunotherapy. Most cases, as you can see from this case, present similarly to bullous pemphigoid, both clinically and histopathologically. And the pathogenesis is not fully known, but BP180 has been found to be expressed in certain tumors. So that's likely relevant. And so I've seen many of these patients, and they really present with a spectrum of findings from mild presentations that look almost like Grover's or prurigo lesions, to urticarial predominant presentations. Others have presented with more mucosal lesions. I've seen patients who have been on immunotherapy and radiation therapy and had the bullous pemphigoid really localized to the radiation therapy. And radiation is known to trigger bullous pemphigoid. And then more typical bullous pemphigoid with urticarial plaques, tense vesicles, bullae, and erosions. And so how do we think about grading and managing these immune-related adverse events? So according to ASCO, a lot of this is based on body surface area and how these drugs impact quality of life. And so for mild rashes that are asymptomatic, often observation is fine. For these cases, in my experience, this is where I'll often try doxycycline, niacinamide, and high-potency topical steroids. For most patients, unfortunately, will present with grade 2 or grade 3 disease. This tends to be very pruritic. The blisters can impact quality of life. And so most will need prednisone. And so while you're using prednisone, immune checkpoint inhibitor therapy is held with the plan that you're able to restart it at low doses and when the rash responds. Rituximab is the recommendation for the severe cases that don't respond. I would say that in my experience, I've had really good results also with omalizumab, as well as dapsone and methotrexate. And so the takeaway points from the bullous immune-related adverse events is that I want you to consider conservative treatments rather than just rushing to prednisone when you can. And if you do need to do prednisone and the steroid-sparing drugs, I'd urge you to consider a targeted approach with omalizumab or rituximab. And so I wanted to highlight kind of the different rashes that I've seen from immune checkpoint inhibitors, because I think these are really important. They're being used more and more for a number of different cancers. Their FDA approvals have been increasing over the past several years dramatically. So exanthems that mimic a morbilliform drug eruption is quite common. I'd say perhaps the most characteristic reaction that we see are the lichenoid dermatitis. So this can present like lichen planus. Others can look more like eczema or psoriasiform lesions. This is an example of a hypertrophic LP case. We've also seen really painful mucosal presentations, which you can see in lichen planus. I'd say nonspecific eczema and pruritus are more common than are described. I think they happen in about a third of patients, especially itch. And the itch can be really intractable in some of these patients, and oncologists have a hard time managing them. Sometimes they'll have to use gabapentin or pregabalin and other antipruritic drugs to help. Vitiligo is an interesting one. It seems to present differently than classical vitiligo. It's often not around periorificial sites like we know classical vitiligo, but it's actually around kind of sun-exposed areas around lentigines, often around the torso. And so this tends to occur mostly in patients with melanoma, but I have seen it develop in patients with many other types of cancer. And I'll discuss the prognostic relevance of that in a second. And so fortunately, more severe reactions don't happen commonly. We have seen Stevens-Johnson reactions from checkpoint inhibitors as well as DRESS. We've seen sarcoid and granuloma annulare, and patients who have had psoriasis frequently will have their disease flare, and they can really be severe flares. New-onset psoriasis can happen as well. Occasionally, we'll see a patient who has a connective tissue disorder, lupus, dermatomyositis, morphea. I've recently had a few patients with eosinophilic fasciitis from checkpoint inhibitors. So one area of interest is whether all these cutaneous immune-related adverse events are associated with a positive tumor response. And so there's been many studies now which have suggested that indeed there is a signal. Those who develop rash, vitiligo, itch tend to do better compared to those who don't. Recently, lichenoid and eczematous reactions, the same thing. I'd say I'm most convinced by the vitiligo literature. I think this tends to be strongest. So vitiligo in patients with melanoma tends to have a very good prognostic indication. And so next I wanted to discuss briefly a case of toxicity from targeted therapy. These targeted drugs like checkpoint blockers are being increasingly used. I'd say this is probably the #1 reason why patients are referred to my clinic. They develop a toxicity from a targeted chemotherapy. So this is a patient who had a purpuric rash on EGFR inhibitor therapy. That's epidermal growth factor receptor inhibitor therapy. So she's a 43-year-old woman with metastatic head and neck cancer, and she was on dual EGFR inhibitor therapy with cetuximab, which is infusion, and afatinib. She presented with a painful purpuric rash on her lower extremities. Interestingly, this rash developed months after being on therapy. During the first few weeks to month on therapy, she developed a more typical acneiform or papulopustular eruption, and that responded to dermatologic therapy with doxycycline. So on examination, on her bilateral lower extremities, she had non-follicular but bilateral symmetrical purpuric papules. Many had overlying erosions. Then on her lower legs, she had purpuric papules. Some of these were folliculocentric. Her face, chest, back, completely clear. No evidence of an acneiform rash there. And so the clinical differential diagnosis, we always think of common things presenting atypically. And so we considered the papulopustular eruption with a very unusual distribution. There's also this entity of purpuric drug eruption from EGFR inhibitors. Some present like eczema craquelé, kind of similar to the way her thighs looked. I'll show you some photos. Anytime you have palpable purpura, you don't want to miss cutaneous small vessel vasculitis. Really didn't fit though well clinically for the thighs. And then folliculitis really probably wasn't consistent either. And so I usually culture any patient on an EGFR inhibitor with a pustular or an erosive rash because these patients are frequently colonized with staph, as she was. And so I recommended skin biopsy given the unusual presentation, but she really had a lot going on and she wanted to treat empirically. And so we treated her with doxycycline and high-potency steroids. And within days of treatment, she had substantial improvement, and I'll show you follow-up photos. She was able to remain on her chemo and had a great tumor response. And so this was 1 week after seeing me with doxycycline and high-potency steroids, and the rash was markedly improved. And so she likely has this purpuric drug eruption to EGFR inhibitors, and I'll show you some photos of it. It's thought to be distinct from the more typical papulopustular or acneiform rash because it's usually non-follicular, it favors the legs, as seen in this patient, pustules aren't always present, and it usually occurs months after treatment as opposed to the papulopustular rash, which usually occurs earlier on. I will say that I think there is overlap with this other condition known as late acneiform toxicity. And so I think regardless of what you call it, it's important to know that you can get these unusual presentations and on these patients on targeted drugs with some lesions that look like vasculitis, other that look more annular, some that have pustules that are not folliculocentric, and others with these kind of eczema craquelé-like features. Histopathology does not show vasculitis. It shows exocytosis of neutrophils and red blood cell extravasation with endothelial plumping. And most of these cases, fortunately, respond to antibiotics. And so here are examples of patients I've seen over the past few years that have developed purpuric drug eruptions while on EGFR inhibitors. They all have a few things in common. So this is the patient that we presented who kind of has these eczema craquelé-like features. They're often in areas of dependence, so the buttocks, the lower legs. They don't always have pustules, but they're almost always positive on culture for staph. So it's important to culture these patients, and they tend to do well. So almost more importantly, I wanted to highlight the toxicities from EGFR inhibitors, many of which I'm sure the residents already know of. They're very common, but this is probably the #1 reason why patients see me in my clinic. These toxicities impact quality of life, and they tend to be chronic, so it's important to know how to, what to look for. So the papulopustular rash, this is very typical for it, inflammatory papules and pustules on the face. This is a very severe presentation on the chest and abdomen that required prednisone. This is a more typical presentation, kind of scattered papules and pustules. Occasionally you can get crusting with lots of staph colonization. Occasionally I see patients develop abscesses or infectious complications. Nail changes are really common from targeted chemo, paronychia, this classical pyogenic granulomas can occur. They're very painful, and patients can develop very painful cracks and fissures on their fingers. Hair changes are very common. Unfortunately, where patients want hair, they lose hair, so there's pattern hair loss. Where they don't want hair, they get it, so there's hirsutism. Then there's this classic trichomegaly, so patients have their eyelashes very long and unruly, and they can sometimes curve inwards and irritate the eyes. So some of my older patients have a hard time trimming, so they'll just see me, so I'll trim their eyelashes every month or so, and that's actually helpful. And so kind of the takeaway pearls from EGFR inhibitor rashes is I want you to consider not just the typical papular-pustular rashes, but you can also get these less common, unusual presentations, such as purpuric reactions. Most respond to dermatologic therapy. And so we spoke about a few different types of rashes we've seen from systemic anti-tumor drugs. So now I wanted to shift gears and talk about radiation therapy, which commonly results in dermatologic problems. And so this is a case of a red breast post-radiation. And so she's a 72-year-old woman with ductal carcinoma in situ breast cancer. She was treated with lumpectomy and radiation therapy 6 months prior. So now she's presenting with new onset pain, redness, and very rapid contracture of her breast that occurred over the course of a few months. Of course, initially, it was thought that she had cellulitis, and so she was given cephalexin without any improvement. Of note, she was on letrozole for the breast cancer, which is a hormonal therapy for her estrogen-positive cancer, and she otherwise was feeling well. No fevers, chills, or other signs or symptoms of a cellulitis. And so her exam was pretty dramatic. Her right breast was extremely contracted and erythematous and tender. And then if you look up close, you see that there was quite a bit of induration to her breasts, almost like a sclerotic consistency. Her nipples were spared, they remained soft. And so the clinical differential diagnosis at this point included radiation-induced morphea, which is rare, but would account for the contracture as well as the inflammation. Cellulitis of the breast really wasn't favored. That wouldn't account for the contracture. There'd have to be also radiation-induced fibrosis, which can happen, but that wouldn't account for the inflammation. One thing you never want to miss in a patient with breast cancer and inflamed breast is inflammatory breast cancer. So biopsy is absolutely needed. And then there's a radiation recall, which means you're on a systemic drug that recalls the radiation dermatitis and it makes it happen again. And that really wouldn't account for what was happening here, but letrozole can cause that. And so biopsy was obtained and was pretty classic for the diagnosis. It was a squared off punch biopsy with increased collagen bundles and an inflammatory infiltrate that was really centered around the eccrine glands, including plasma cells. Special stains were negative for breast cancer. And so the patient was diagnosed with radiation-induced morphea. So given her extreme presentation, I recommended more aggressive management, but she was a little bit hesitant to undergo immunosuppression with prednisone or others. And so we started off a bit conservative with high-potency topical steroids and phototherapy with narrowband UVB. This really didn't do much. Eventually, we were able to convince her to try more aggressive treatment, and so we started her on UVA, which penetrates more deeply, as you know, and methotrexate, and she had a remarkable improvement. 3 months later, when we saw her back in clinic, her breasts were much softer. As you can tell, this kind of this thickening sclerosis was a lot softer. Her symptoms felt a lot better. So she had a great response. She was able to stay on UVA phototherapy, I think like once weekly maintenance, and methotrexate, and she continues to do very well. Her breast cancer remains in remission. And so radiation-induced morphea is not common. It's in the literature, they'll cite rates of 1 in 500 patients. I've seen a lot of these patients, so I think it's probably under-recognized and not diagnosed correctly. I think it's actually more common, and so it's something that I think you should know about. It can present months to even years later. I've had some patients present a decade after radiation with morphea of the involved breast. And so you can get these very interesting delayed reactions. And so, like typical morphea, there's really an acute phase where you get inflammation, often with this violaceous lilac halo. They're often round plaques. But I do want you to know that it's not always localized to the areas of radiation. I've seen plenty of these cases generalize throughout the body, even though they start in an area of radiation. Then the chronic phase, like regular morphea, often more sclerotic with hyperpigmentation. I'd recommend biopsying all of these patients to rule out breast cancer and to confirm your diagnosis. The histopathology of radiation-induced morphea is pretty much the same as classical morphea. And so we conducted a study that looked, it was Yale, Stanford, and Northwestern, that looked at what's the best way to treat these patients. It was retrospective. Most patients did well if you treated them early on in the inflammatory phase, with usually a combination of topicals, phototherapy, or systemic drugs. Prednisone, methotrexate, Cellcept, tofacitinib, and photopheresis were medicines that were used that induced a complete or partial response. And so I wanted to highlight some of the patients I've seen over the past year with radiation-induced morphea. This is a very typical presentation around patch or plaque on the breast area, And the inflammatory phase, you see this violaceous lilac rim. I don't know how well it's projecting. Other patients present with more erythematous plaques. This patient here had a lesion on her breast, and then she had these generalized morphea-form plaques extending onto her torso and lower legs. I've even seen some patients present with morphea and lichen sclerosis-like features with these ivory white papules and plaques. So I think some of this does lie on a spectrum. But I think it's important to know the different problems, the toxicities that can happen after radiation therapy, because you always need a differential diagnosis when evaluating these patients. So acute radiation dermatitis happens in most patients, usually days to weeks into treatment. It often presents with these localized areas of erythema and dry desquamation. There is this radiation recall dermatitis, as I mentioned earlier. So these patients are on a systemic medicine, usually a chemo, but could also be hormonal therapy that can re-trigger the radiation dermatitis. So that's important to keep in mind, because you might not be able to put it together unless you realize that radiation dermatitis can happen months to years later due to a systemic recall. We have seen patients present more severely with more generalized lesions or moist desquamation. This almost looks like really severe TEN-like changes under the breast. Very painful ulcerations can happen. The risk factors for the development of more severe radiation dermatitis include the target of radiation closer to the skin, higher dose, higher body surface area of radiation given, and being on a concurrent chemotherapy, which can radiosensitize you. And some of the patient-specific risk factors include patients who are obese or have increased skin folds, have connective tissue disorders, or have a genetic DNA repair deficiency. Chronic radiation changes can happen as well. These include telangiectasias, atrophy, and dyspigmentation. Unfortunately, radiation-induced fibrosis can be really severe. This is one of the most extreme cases I've seen. This patient's breast completely contracted, and she, believe it or not, she actually had brachial plexopathy. She had trouble with her nerves. They were damaged from the radiation as well. Very severe case. There's not great treatments for radiation-induced fibrosis besides physical therapy, and some have tried pentoxifylline, but really there's nothing great out there for it yet. Inflammatory breast cancer, as I mentioned before, you don't want to miss it. It can mimic cellulitis, erysipelas, really important. This is very often misdiagnosed by others as an infectious cause until they see dermatology. And then I did want to point out that radiation can actually trigger inflammatory dermatoses. I've seen new onset bullous pemphigoid develop in radiated breasts, and I showed you earlier, patients on immunotherapy and radiation can get bullous pemphigoid that's really severely localized to the area of radiation. Psoriasis can also Kebnerize into radiation dermatitis as well. And so shifting gears from inflammatory reactions, radiation can also trigger carcinogenesis. And so not just basal cells and squamous cells, but also vascular proliferations. And so this lies on a spectrum. There's the benign growths of atypical vascular lesions. It sounds atypical, but they're benign. There's many names for them in the literature. Lymphangiomatous papules is something also that's described. These lesions often look like red papules. They can look like hemorrhagic vesicles or even large hemorrhagic bullae. Then there's, on the other side of the spectrum, angiosarcoma induced from radiation. This is really severe, tends to have a very poor prognosis with high rates of local and systemic relapse. So biopsy, any lesions that look concerning. And so the takeaway pearls from radiation-induced morphea is they can happen months to years after radiation. You want a biopsy, and I'd say the most important takeaway is you want to treat these patients early on in the inflammatory phase before that debilitating scarring and contracture happens. And so we spoke about a number of different direct problems that can happen from cancer therapy. So now I wanted to shift gear and talk about some indirect complications that we frequently see in our clinic. So this is a case of ulcerative lesions and a monoclonal gammopathy of determined significance, not undetermined significance. And so the lady is a 48-year-old woman who presented with initially pustules on her hands and her feet. They developed new onset. She eventually went on to develop these painful draining ulcers on her lower legs. Really dramatic presentation. She was otherwise healthy and felt well on no medicines. So her hands and her feet had numerous vesicles and pustules. Many had overlying erosions with scale and crust. It was quite painful. And then on her lower legs, bilaterally, she had multiple of these large ulcerative plaques. Note they had a violaceous rim. Some had a more cribiform appearance. There was a fibrinous base with granulation tissue as well. And so based on this presentation, really the top thing on the differential diagnosis was a neutrophilic dermatosis, such as pyoderma gangrenosum, or really atypical bullous presentation of Sweet syndrome. We also considered a medium vessel vasculitis, such as granulomatosis with polyangiitis. Halogeneoderma is considered as well as an immunobullous disorder that can present with pustules like IgA pemphigus. Pyoderma vegetans, which can be associated with inflammatory bowel, and infections. You never want to miss infectious disorders such as blastomycosis like pyoderma or deep fungal or atypical mycobacteria. That was less likely given how extensive this was. She was feeling very well. And so we were hoping it was not going to be infectious. But biopsy and tissue cultures were indicated. And so on biopsy, there was an ulcer with a very dense inflammatory infiltrate that when you zoom in was composed predominantly of neutrophils. There was occasional lymphocytes and plasma cells as well. PAS, GMS, and gram stains were all negative, and immunofluorescence studies were negative as well. Importantly, tissue cultures for bacterial, fungal, and atypical organisms came back negative, and so we weren't looking at an infectious process. We made her get a colonoscopy to rule out one of the important associations with the likely diagnosis that was negative, but she was found to have on her SPEP and her immunofixation, always checking immunofixation, by the way, not just SPEP, or else you can miss the IgA. She had a monoclonal IgA band. And so the patient was diagnosed with IgA gammopathy-associated pyoderma gangrenosum. And so she was seen by hematology for a bone marrow biopsy to rule out myeloma, and the bone marrow biopsy had less than 7% plasma cells, no other stigmata of myeloma, and so hematology diagnosed her with MGUS, monoclonal gammopathy of undetermined significance, and brought the ball back to Derm and said, you guys treat her with skin-directed therapy. And so she was given IV steroids with slow prednisone taper. She actually improved pretty promptly, like neutrophilic dermatoses often do, but upon tapering doses of steroids, the whole thing came back. And so we were looking for steroid-sparing options at this point. And so she was treated with intravenous immune globulin twice monthly for many months. Didn't really help at all. She saw another dermatologist who tried mycophenolate mofetil, also for several months without any help. I would say probably the thing that was most helpful at this point was the wound center to kind of help her with all of her dressings and keeping the wounds clean, but careful not to do any major surgical debridement given the pathogy from these neutrophilic dermatoses. And you can see, really she had neutrophilic plaques on her torso, spreading everywhere. It was really a very severe case. And so at this point we had to regroup, and I called back the hematologist and I said, this is not monoclonal gammopathy of undetermined significance. This is monoclonal gammopathy of dermatologic significance. This is clinically significant here. So we need to regroup. They repeated a bone marrow to make sure she didn't have progression to myeloma, and she did not. Her bone marrow looked better than before. So clearly there was a disconnect here. And so eventually there was an agreement that hematologic directed therapy was indicated, and we were really glad. She did remarkably well. A month after starting cytoxan, bortezomib, which is a proteasome inhibitor, and dexamethasone, she had remarkable reepithelialization. This is after months and months of failing multiple systemic therapies. All of her vesicles and pustules were drying out, and her neutrophilic plaques were fading with hyperpigmentation. I continued to follow her closely. She had remarkable improvement. Her largest ulcers all reepithelialized. Here's one example. And the rest of her lesions, pretty much she had scarring. A lot of these were deeper lesions, scarring and hyperpigmentation. But her life was dramatically improved. I mean, this was a woman who was doing just terribly. And so monoclonal gammopathy-associated pyoderma gangrenosum, as seen in this patient, is often associated with the IgA subtype. You should also note the IgA subtype is a higher risk gammopathy, more likely to progress to myeloma. You really have to follow these patients closely. It can also be associated with other hematologic disorders, such as AML, non-Hodgkin's lymphoma. And regarding Sweets-like presentations, you'll often see in textbooks discussion of bullous or atypical presentations. I mean, seeing from this case, clearly those that are driven by hematologic disease can be very atypical and bullous and dramatic. The way PG is treated in general is with steroids and steroid-sparing drugs, anti-neutrophilic drugs such as colchicine, dapsone. TNF inhibitors are becoming very popular. I would urge you not to use the TNF inhibitors first line. There are some case reports of actually progression of gammopathy to myeloma during a TNF inhibitor. So I would recommend, in a case like this, that you discuss with a hematologist what the correct diagnosis is, and you would manage the underlying disease that's driving it. And so the takeaway pearls from this is make the diagnosis of monoclonal gammopathy of dermatologic significance. I think this is something that really needs to be communicated to the hematologist who might not understand that if the bone marrow looks good, this is still a relevant disease that needs to be treated. And so, in the final case is a case that I like a lot because it's very simple. And it's something that we see all the time, but just didn't respond to standard therapy. And so I think it's a good lesson. And so this is a case of a cold sore gone mad in a lady with myelodysplastic syndrome. And so this is a 63-year-old woman who presents with an enlarging ulcer on her lip she's had for a few weeks. She had a history of myelodysplastic syndrome. Unfortunately, she had progression to AML despite a bone marrow transplant. She did have a history of cold sores. She was on azacitidine for her chemo for AML, and of note, she was on Acyclovir prophylaxis for herpes infections. Otherwise, she was feeling well. This was one of the first cases I saw as a first-year attending, I think maybe the first week. And so I felt pretty good about the diagnosis from looking at it. There was an ulcer with a hemorrhagic crust on the lip that was extending onto the cutaneous lip. And so the first, second, and third things on my differential were oralabial herpes simplex. I didn't think it was impetigo or traumatic ulcer. I didn't think it was syphilis or anything else. And so I did a swab, and I treated her empirically. So she was on Acyclovir, but I changed her to a therapeutic dose of Acyclovir, and I was planning to treat her until the lesions were fully resolved, because I knew in a patient who was immunosuppressed, you need to do that. And so I was feeling really good about myself. And then I knew I was in trouble, because a week later, she calls my nurse and says, tell Dr. Leventhal to come down here. His diagnosis is all wrong. The ulcer's taken over my entire lip. And so it was hard to believe. I thought it was a joke. But then when it came down there, I was like, oh, wow, it really was taking over her whole lip. And she had new lesions on her upper palate as well. And so we went back to the labs. Her PCR was positive for HSV1. Her cultures were negative otherwise, and she was pancytopenic. And so we figured she must have had Acyclovir-resistant oralabial herpes. So we called the virology lab and said, let's find out if this is a case of resistance. They said, okay, we'll get back to you in 2 weeks when it's back. I said, well, that's not helpful. And so at this point, we had to make a clinical decision. And so I called up my friends in infectious disease, and they came to see the patient with me. A decision was made to hospitalize and treat for the standard of care, which is IV foscarnet. She did remarkably well. 2 weeks later, the entire thing was resolved, which was really remarkable. And also 2 weeks later, I got that phone call confirming that the diagnosis was indeed Acyclovir-resistant HSV. And so Acyclovir resistance is something we don't think about maybe too often, but herpes is really everywhere, so it's important to keep it on the back of our heads. It's really more common in patients who are immunosuppressed, especially bone marrow transplant recipients, such as this patient. Most will have a history of exposure to Acyclovir for prophylaxis, and then they get a mutation in the viral thymidine kinase. Think about it in patients who have atypical lesions. They're larger, they're verrucous, they're exophytic, they're not responding to treatment. And the treatment of choice is intravenous foscarnet. Cidofovir is another option. It's not always readily available and more expensive. And if you look through the literature, you'll see reports of patients with atypical herpetic infections and they're immunocompromised. This is an example of more of a verrucous and exophytic lesion in a patient who was on azacitidine as well. This is a patient who had a renal transplant, I should say, who had these persistent verrucous plaques not responding to antivirals. Then they did PCR and immunohistochemistry, which was both positive for CMV. It wasn't until the patient's CMV was treated that the lesions resolved. So consider CMV as well, and these unusual ulcerative lesions in immunosuppressed patients. And so the takeaway pearls here are that you really need to consider antimicrobial resistance in cancer patients or others who are immunosuppressed. Many times you actually have to make a clinical diagnosis and a decision to treat with a standard of care therapy. And so in these last 45 minutes, I gave you kind of a tour of the many different types of patients that we see in the Oncodermatology Clinic, both inpatient and outpatient. A few take-home lessons that I want you to remember are, I want you to consider unusual and atypical presentations of common things, such as toxic erythema of chemo and EGFR inhibitor rashes. You can really get very dramatic atypical presentations. Remember that bullous reactions to checkpoint inhibitors, while not common, can occur much later on. I'd urge you to consider targeted approaches in patients who fail conservative therapy. Radiation-induced morphea can also happen months to years later. It's important to make that diagnosis and treat patients early on in the inflammatory phase, or else they're going to be left with increased risk of scarring and contracture, which is debilitating. Don't forget to communicate the correct diagnosis of a monoclonal gammopathy of dermatologic significance to hematologists and explain to them the indication to treat patients who have really severe disease that's resistant. And then finally, I want you to remember that antimicrobial resistance is something that is more associated with immunosuppressed patients, and so you always want to keep it in the back of your head. And so in conclusion, I think I gave you a little bit of an idea that cancer patients can have a lot of problems, and us as dermatologists can really play a very important role in the multidisciplinary care, not just by making diagnoses, but by palliating their toxicities, improving their quality of life, and keeping them on cancer drugs. And so I wanted to thank you all for your time.